The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon and welcome to the Academy's webinar on the 2015 Physician Payment Rule. We'll focus on the Chronic Care Management Service. We'll also make note of payment programs that ended in 2014 or that will sunset at the end of this calendar year. Provide clarification on the home health face-to-face encounter, that the encounter remains required, that the narrative itself is no longer required. We want to leave 20-30 minutes for questions this afternoon as the Chronic Care Management Service is a new service and provide opportunity for your discussion and your questions and observations for each other as well. We will post the slides and the referenced materials to the Academy site. We will develop a subheading in the practice management section under coding and documentation for the chronic care management services. Along the course of the webinar, please submit questions at any time. And again, we will try to answer those at the end of the webinar or provide any answers that we have to research. Okay, so the 2015 Medicare Final Payment Rule. The Medicare fee schedule for home care medicine services has been posted to the Academy site. There have been some revisions based on technical corrections to the conversion factor between last year and this year. This year's conversion factor, as you see, is $35.75, about 7 cents for technical correction reasons from as compared to 2014. As we know, the sustainable growth rate formula issue is still unresolved and under current discussion in Congress. The Academy is working with others to use independence at home and savings that would be attributable to expansion as a means to resolve the STR issue. And we will certainly keep you informed regarding STR development. So that conversion factor remains in effect through March of this year. In the fee schedule information that was posted to the site, we've also added this year distinct columns for nurse practitioners and physician assistants. In discussion about chronic care management, we'll provide the information about the coverage and payment background, code descriptor information, elements of service, which are CMS elements of service, and services that are excluded if rendered in the same month. Discuss code implementation observations that have really been forwarded and contributed by your Academy member colleagues, which we appreciate. We'll discuss the use of the Chronic Care Management Service for practice transformation and positioning your practice for value and why this is important. And again, time for questions and discussion. And the code is really a starter for practice transformation, and CMS in the final rule actually provided language to this effect and why it was being provided to practices, in addition to, of course, the beneficiary care aspects. The final rule for this year, finalized CPT 99490 for chronic care management. It is a monthly service code. The service is not part of an evaluation and management encounter, nor is an evaluation and management encounter nor annual wellness visit required as a prerequisite for the chronic care management service. CCM payment. Here I just wanted to break out so everybody could see the national allowed amounts, the physician column, and then the nurse practitioner PA column. This service has the Medicare 20% coinsurance. It is not a preventive or screening service. It is also not part of the primary care incentive program. And it also requires the consent of beneficiaries to receive the services, which we'll talk about, as the services, many services are rendered non-face-to-face. So CMS did not want any beneficiary or caregiver surprises when explanation of benefits, and then your bills for the 20% co-payment were received by the beneficiaries. Regarding non-Medicare payers, I would use the Medicare coverage and HIPAA as levers in discussions with non-Medicare payers. We don't see a lot of information out there yet in literature. Perhaps some of you can share what you're experiencing by discussion this afternoon. I would always work to revise contractual agreements to include language such as observing the codes then in effect covered and paid by Medicare. And this one serves as an example as TCM a couple of years ago, et cetera. Would work to obtain commensurate or more value through non-Medicare payers, through care management arrangements, that is if they're not covering and paying for the CPT code discretely itself, through care management arrangements, care transition agreements, hospital admission avoidance agreements, and the like. February is the first month, because it was a monthly code, and we're still finishing up January. February is the first month when claims would be paid by Medicare. And if you've already received claims for one reason or another, perhaps they are being held. Again, it would be interesting to see if you've received any adjudication explanation of benefit information from Medicare. Our understanding is that, again, with a monthly code, they would not expect to receive a code until the last day of the month or the following first day of the following month at the earliest for this monthly code. There is recognition that not all months are of equal days, but again, it was established as a monthly code. In terms of a technical matter, whether a range date or the end of the month date would be in the field for data service, it's not certain. It may be up to the specific contractors, but we will keep our eyes open for that and provide that information. And again, some of you in discussions with your contractor may be getting that information as well. CMS has established a national provider call on February 18th for this code. Registration's available. We'll put that out in the Monday electronic news as well. CMS is using the final rule for 2014 and 2015 as the basis for their adjudication and establishment of the code rules, and they recommend review of that material, which we'll post to the site, and that's the basis of the information you'll be seeing this afternoon. And we'll also keep our eyes open and let you know when Medicare Carriers Manual instructions and MedLearn materials are available. So the code descriptor: at least 20 minutes of clinical time directed by a physician or other qualified healthcare professional per calendar month, with the required elements of at least 2 or more chronic conditions expected to last at least 12 months or until the death of the patient. The chronic conditions place the patient at significant risk of death, acute exasperation, decompensation, or functional decline. A comprehensive care plan is established, implemented, revised, or monitored. So we're seeing that you're starting to get paid for service you're already rendering. You want to make sure that you're entering diagnostic codes. And for this service, as others, there is that relationship of the diagnosis codes to the chronic care management services, so that would need to be there. And those would be the diagnoses that you're managing for the code service to exist. Also note the care plan language, and there is discussion that establishing the care plan itself is countable time. Again, this would not be part of the evaluation and management service that you're rendering any particular day. But again, that would be work that you would be doing outside of an evaluation and management service. I would embed the elements of the work to embed the elements of service in your practice. The elements of service that we'll be reviewing will be required in additional codes and payment models in the future. Would use the service, the elements of service to develop and expand relationships based on these elements into the community, and in essence to create your patient and practice ecosystem. We are also working, the planning committee for the annual meeting is working to get sponsors and exhibitors that would support the elements of service to participate and support the Academy and provide the opportunity to review their services and have discussions with them at the annual meeting. These would include EHR providers, logistics organizations, predictive analytics, telemonitoring, etc. So the elements of service. These are required as part of the monthly service to be incorporated and documented as part of your ability to receive payment for the service. Access to care management services 24/7, providing the beneficiary with a means to make timely contact with healthcare providers in the practice to address his or her urgent chronic care needs regardless of the time of day or day of the week. At present, the terms of timely contact or urgent chronic care needs have not been further defined, and perhaps we'll hear more about that on the February 18th CMS provider call. At this time, I would use what you find reasonable for the circumstances from the perspective addressing urgent chronic disease needs. Continuity of care is the next element, with a designated practitioner or member of the care team with whom the beneficiary is able to get successive routine appointments. Care management for chronic conditions, including a systematic assessment of the beneficiary's medical, functional, and psychosocial needs. Again, hopefully you're already providing these assessments. System-based approaches to ensure timely receipt of all recommended preventive care services. So this would be a holistic approach, and also alerts in your system for any services that the beneficiary would need. Medication reconciliation with review of adherence and potential interactions, and oversight of beneficiary self-management of medications. Creation of a patient-centered care plan. And here I begin to mark some of the elements that do need to be documented into a certified EHR. The EHR has to be certified to the prior year that was established for meaningful use. So for the code this year, whatever system that you would have had available for meaningful use last year, the 11 or 14, would be suitable, and that would be needed to be used. It does not mean you're going to acquire meaningful use status this year. It just means that that system is the one that needs to be used for the purposes of this code. And this is one of the elements: creation of a patient-centered care plan based on the physical, mental, cognitive, psychosocial, functional, environmental assessment, inventory of resources and supports, a comprehensive care plan for all health, and that you'd share the care plan as appropriate with other practitioners and providers. Again, this brings us back to use the code to knit the practice to vendors, suppliers, professionals, community supports. Structured clinical summary record. Again, this needs to be in the certified EHR. Structured recording of demographics, problems, medications, medication allergies, and the creation of a structured clinical summary record, full list of problems, medications, and medication allergies. And this information must inform the care plan, care coordination, and ongoing care, clinical care. This is a piece that Medicare also wants available to those outside the practice or others that would be seeing and managing the patient as part of the services of chronic care management. This information does not need to travel. It's not required to travel through an interoperable EHR or even a certified EHR. It has to be stored in your certified EHR. It does need to travel electronically and cannot be faxed. Next item that needs to be in the EHR is providing the beneficiary with a written or electronic copy of the care plan and document its provision in the electronic medical record. Next item, management of care between and among healthcare providers and settings, including referrals to other clinicians, follow-up after an emergency department visit, and follow-up after discharges from hospitals, SNFs, or other healthcare facilities. Again, this is important to get connected with other settings in terms of the care of the patient, their care transition and management, and the medical record. There's no timing requirement like in the transition care management service of seeing a patient within 7 or 14 days or in independence of home within 48 hours. But again, it would be timely and relevant to that patient's circumstances. Beneficiary consent. There's various required elements informing the beneficiary of the availability of the services. Obtaining the written agreement to have the services provided, including authorization for that electronic communication of medical information with other treating providers, documenting in the medical record that the services were explained and offered, and whether the beneficiary decided to accept or decline the services. We have posted a sample beneficiary consent form to the Academy site, and then we'll incorporate that under this subheading of the chronic care management service. Another item of the beneficiary consent that's required is to inform the beneficiary of the right to stop the service at any time. Because it's a monthly service, it would then be effective at the end of the month, then in effect. And you would also explain the effect of a revocation is that the chronic care management services may no longer be rendered or available. If there's a revocation and for some reason there was a change of mind of the beneficiary to, again, renew the services, then you'd need to have a new beneficiary consent established. However, from our understanding at present, once you start with an initiation under the care plan, for those chronic conditions, again, until we see otherwise, it would seem that the original beneficiary consent would suffice for the duration of rendering those chronic care management services. Okay. CMS recognizes that services and care management here may be duplicative of other services you're currently rendering that are also documentable and submittable to the program. So they're only going to pay for one service for the same month for that beneficiary. Here we've listed the CPT codes of the services, the different services that are described that only one of these would be paid during a month. We have the monthly allowed amount that you can see. And in the right-hand column, a note of whether evaluation and management services receive separate payment. For the chronic care management services, they do. For the home health and hospice care plan oversight, they do. In transition care management, we know that one face-to-face evaluation and management services is required within the 7 or 14 days. Other medically necessary E&Ms are paid, and that also is reflected in the various payment levels as well. Also that, so the two TCM codes, and then there are some end-stage renal disease services as well, that again, only one of these services would be paid by Medicare in the same month. So we want to discuss some of the implementation observations and tips from your colleagues around beneficiary identification and agreement, certification of clinical staff so that time counts, tracking time to meet the 20-minute requirement. In terms of beneficiary identification and agreement to receive some services, some of the tips have been to run reports on diagnostic fields to identify existing patients with 2 chronic conditions, assure that all staff are entering accurate, complete diagnostic codes each encounter. This, of course, is across the board for all services. Run reports to identify home health, hospice patients receiving CPO, and then build out from these patients for whom you may not be reaching the 30 minutes, because now then this is another care management service opportunity for documentation by others than the physician providing the care plan oversight, and also payable, and the 20 minutes or less than the 30 minutes as well. Build the beneficiary agreement into new patient intakes for new patients. Again, we have a sample agreement on the Academy site. Obtain agreement with other beneficiaries as the diagnostic requirements for CCM are met. And then do this in a way that you're communicating the ability that this code and the agreement is providing you the ability to provide additional services to the beneficiary. A practice approach. Clinical staff, the services are your services or those rendered incident to your services, does not have to be under one roof. Again, Medicare recognizes that this is a 24/7 service and can be rendered non-face-to-face. The definitional term at issue here is a clinical staff. So some practices approaches to make sure that only clinical staff are rendering care management, and clinical staff would be include RNs, LPNs, licensed clinical social workers, medical assistants, and various other certified paraprofessionals, etc. Some practices are doing that by practice design and redesign so that only clinical staff are rendering CCM. And of course, on an ongoing basis, you can do this by recruiting clinical staff, even administrative staff that have clinical certification, as some of you may have had non-clinically trained staff who are rendering care management services now, yet they do not have any clinical certification. And then you could also do this by establishing training of staff and application to become certified by an accrediting organization. Some practices are doing this by contacting the educational organizations offering education and training to become certified. Some are actually having that educational content delivered on site. Assisting in the completion of certification process for the staff, and that it's a good value for the practice, and certainly an enhancement for the staff and care beneficiaries as well. The expense is paid through the ongoing payment of the chronic care management service, and again, it is considered a starting point for additional levels of payment for chronic care management in the future. Tracking time to meet the 20-minute requirement, educate staff as to code and time requirements, create a system, alerts, flags for patients that receive chronic care management, just like any other payer-specific program, or diagnostic condition alerts in your system, so that anybody accessing the medical record treating the patient is aware that they're receiving that service, and they want to make sure that the time, the narrative of the services and the time is documented. You would create structured fields so that the time can be entered associated with the medical record documentation, and that you might include that time either in narrative form or start and stop entries. Create macros that provide a running cumulative total for the structured time field, and then create a report to pull that information by that field at the end of each month, so that you can see whether the 20 minutes has been satisfied, and then you'd submit that the service for Medicare payment. Compliance and chronic care management. Compliance is part of overall risk management for a practice. Compliance plans are also required by the Affordable Care Act. Good practice to establish that understanding of the provider-patient relationship must be established. Primary care provider of record, only one provider. This code is not restricted to primary care providers only. It's available to all providers. However, Medicare will only pay one provider that has been recognized and the services are consented to by the beneficiary for them to receive services in a given month. So that's why you do want to establish those relationships, as is also required for the TCM coverage and payment. It's required for ACO and shared savings program attribution, and it's good compliance practice for Medicare Part B services. How does the CCM code contribute to practice transformation and positioning for value, and why it's important? Well, if we just look at some of the elements as we've been discussing, the beneficiary relationship and attribution, again, it's required for the coverage and payment. It's important for the value-based payment modifier program required for ACO shared savings program attribution. Home care medicine practices that you're in, operate in, and growing. You'll have value through the high-risk, high-cost beneficiaries that you manage and whose cost your services in turn reduce. So it's important. So you're bringing value to ACOs and shared savings programs through your services and beneficiary panels. So it's important to have that relationship documented and attributed to you. It's important to track facility and PAC utilization so you can demonstrate value to ACO and shared savings programs, and it's important to be in a position of negotiation with payers and post-acute care organizations and bundling programs in the future. Again, we want to help you to position yourselves to be in a situation where you can determine and create and negotiate your own future in this move towards a value-based payment system as things migrate away from fee-for-service, and this code will help you to do so. Care management and management of care transitions. You want to develop informal and formal relationships, again, with the post-acute care community. You want to develop relationships with community resources, the patient practice medical neighborhood, and get deeper and have recognition of your practice, even more thoroughly recognized there, and vice versa, to understand the resources in the community that are available for you to care and manage for the patient. And that includes relationships with ALS and other settings. Management of care transitions, and you want to use the service to develop a proactive practice of leadership, culture development and staffing, development of internal and external practice relationships for coverage. The beneficiary access 24/7, it can be someone from within the practice or it can be external to the practice, provided that the services, again, are documented in that certified EHR. But this code gives you an opportunity to develop those relationships. Also with health systems, again, post-acute care centers, care facilities, call centers, communication hubs, EMS organizations as well. The use of technology to engage and an opportunity to engage your vendors and develop practice understanding. We've discussed the need and the use of the EHR, the structured data and pieces of the medical record that have to be there for communication and care coordination. This will be increasingly important in the future for risk stratification based on diagnosis, group, socioeconomic status, and there is currently information that zip code is becoming as important as genetic code in determining the health status of your patients and their management. This all leading to population health management. Telemonitoring is an example of technology. The time of your reviewing data counts towards the monthly requirement. The time that a device is worn by a patient entirely is not countable, but just the time of your, again, reviewing, interpreting that data, and again, with your documentation of same, does count towards the monthly requirement. Also, technology and information systems will contribute to your reporting and the financial management and risk-adjusted diagnosis-based models that many of you are already in, and others will be entering and will be becoming more prevalent across the market and across the country, and will also contribute to continuous quality improvement efforts. As an example that came about was seen this week in terms of risk stratification and high-cost patients, a healthcare transformation task force provided an announcement of a private sector initiative to move more healthcare payments away from fee-for-service and towards value-based and quality and outcomes-based payments. And from their site is this work that one of the areas of work they're going to focus on in 2015. And I wanted to mention that the patient population relevant to Academy members, addressing risk stratification of high-cost patients, implementation of programs to perfect handoffs and improve coordination among high-risk integration care programs, and assure patient family-centric care, better outcomes, lower cost, disseminating best practices for identifying and improving care for patients at the end of life, high-cost events, and patients with multiple chronic disease, including those with underlying chronic behavioral health where traditional disease and case management is not effective. And of course, we can all recognize that this page and this initiative of theirs likely represents a large patient group of your patient population. The Academy has funded research and is seeking more funding for research to inform payment policy around your high-cost patients. And indeed, if the private sector has interest as noted above, then certainly this is an important development. A page of this slide is here with some practice revenue examples by how many months of chronic care management you're providing to a beneficiary, and then also just extrapolated by the number of patients. And again, you can see how this is a contribution towards some of that, the infrastructure and the costs and services that are involved in developing the capacity to satisfy the elements and render the and document the chronic care management service. Provided a sort of a wrap-up or summary slide here that we've discussed in terms of the service timing, the consent, the claim submission adjudication, the incident to that other staff, internal and external now of the practice, can work under your services incident to under general supervision to render accountable service. So it need not all be W-2 employed staff. We talked about the duplicative service exclusions. There's an RVU figure there for practices that are use that in terms of supporting the productivity of the practices in terms of practice budgeting with organizations, the payment levels, the co-payment issue, and that it's not part of the primary care incentive program. Okay, this week's forces of transformation. I'm going to go quickly now to leave some time for questions. And of course, one transformation force that raged across the country was Juno. As mentioned, there's been transformation initiatives announced. On Monday, the Department of Health and Human Services Secretary Burwell announced measurable goals and a timeline to move the Medicare program and the healthcare system at large towards paying providers based on the quality rather than the quantity of care they give patients. And then on Wednesday was the private sector initiative mentioned of an alliance dedicated to accelerating the transformation of the U.S. healthcare system to value-based business and clinical models aligned with improving outcomes and lowering costs. So we clearly are in the care coordination management practice transformation to value station. This slide reflects the percent of payment and that have aspects or quality or value-based models from Medicare or for the private sector in the announcements this week, and we can see that we are really well on our way to into these years that these high percentages of payment tied to quality and value versus just a fee-for-service productivity or volume basis is occurring. Medicare wants 85% of services paid with some aspects to quality or value basis by 16 and increasing to 90% in 2018. And then by 2020 we see that again, that 90% figure, and the private initiative I mentioned has a goal of 75%. And this includes models such as accountable care organizations, bundled payments, etc., in addition to those being paid just on the existing quality measures such as PQRS and the value-based payment modifier. So there's still time to get on the train, and we do not want you to be left chasing the train. Your home care medicine practices have tremendous value. So we're moving from the Medicare and private fee-for-service environment. That is going to be in place, and this code is an element of that. In the middle box, we have our evaluation and management services, the CERT, research, CPO, transition care management, now chronic care management service. And again, we are heading to using, and we want you to use the code in these services again as the means to transform your practice and demonstrate that value to ACOs, health systems, post-acute care environment, managed care plans, and others. Real quickly, payment programs that have sunsetted or will sunset this year, the Medicaid rate increase that was from the Affordable Care Act for 2013 and 2014 is now over. It is up to the individual states whether they wish to continue to pay Medicaid services at Medicare rates from this year forward. We'll post what we know about those states, again, also on the site. What I'd like you, hopefully you know whether you've been receiving those increased payments for 2013 and 2014 as well. The primary care incentive program is ending at the end of this year, and again, we know that that's been an important contributor to the revenue for Academy member practices. And in some regards, it may be that CMS views the chronic care management service as a bit of an offset since that program is sunsetting at the end of this year. Home Health 2015 face-to-face encounter remains required. The narrative as an additional standalone document is no longer required, and we will put the site, reference to the site on the Academy site, and we've sent that out, and we'll reference that again. There can be claim denial for your certification services if the home health episode is denied. Access to home health agency documentation is permitted for incorporation into your medical records as to why the home health services are medically necessary. Again, the face-to-face encounter remains required for certifications, and the face-to-face encounter as an evaluation management service continues to be paid. Again, your home care medicine practices have tremendous value. Let us help you share with your colleagues, and also we hope to see you at the annual meeting in May.